Hi, welcome to Black Beetle Health in Talks With. My name's Adelaide. I'm a registered midwife and I'm also the Health Education and Community and Resource Development Officer. Get it right? For female health. Today we're going to be talking to one of our friends, Dr. Annabel Sowemimo at Decolonizing Contraception. So we're just going to add Annabel to the conversation now. Cool. Hello.
Hey, hi.
How are you
How are
doing?
you?
Good to see you.
Yeah,
Good, really
I'm
good. Thank you. Thank you so much for joining us. So I'm going to just do a little introduction, just pick you up, obviously,
thank
and
you.
then you can just kind of fill in any gaps and just tell us a little bit about yourself, if that's okay.
Yeah, great.
So everybody, this is Dr. Annabel Sowemimo from Decolonizing Contraception. Um, you were the founder of this kind of community interest group. You're also a doctor of sexual and reproductive health. And take it away. Add anything else that you would like to. Thank you so much for joining us.
Thank you so much for proposing that we do this live. So yeah, no, that's me. So Decolonizing Contraception is a collective of Black and people of colour working in sexual reproductive health, and we can talk about terminology and why as the live goes along. But yeah, so it means that I work in community, doing kind of community gynae, contraception, sexual health, as well as work in the hospital doing kind of outpatient things like menopause, and pregnancy, miscarriage, that kind of thing as well. So cover quite a broad range of areas. Outside that, I'm also a journalist,
Yeah.
and outside that, I also am a trustee for MedAct, which is a health justice charity as well.
Brilliant. And I believe that in your kind of journalism work, you're a regular contributor to Galden magazine as well.
Yeah,
So
so
some people might have seen you there.
I wrote a column for Galden called Decolonizing Healthcare, which is all about kind of talking about how the history of healthcare also affects some of the healthcare that we see now, discussing kind of the history of medicine, talking about health inequalities, also just talking about how we view our own bodies in our own communities, and just trying to kind of promote discussion that we don't conventionally kind of have in the mainstream.
Great, brilliant, thank you. So you kind of touched on it a little bit already, I guess, but it would be really great if you could share sort of what was the catalyst for founding Decolonising Contraception.
So initially when I started, it started from an article that I wrote at Geltham called Decolonizing Contraception. And that was discussing kind of the history of medical experimentation in sexual reproductive health, how we don't really discuss how that affects our healthcare and things like that today. And I wrote that article and lots of people kind of got in touch, and both people working in the field and then also people just that read Galvin generally. And I felt like we had to have more of those conversations in person. So then we started doing events, and then after doing events and things like that, it kind of grew and spiraled to include sorry.
It's okay.
And it kind of grew and spiraled into just doing more articles and then meeting with like-minded people and trying to do more events. Yeah.
Brilliant, amazing. And so one of the events that we're aware of that kind of is on hold at the moment is Sex Fest. So I don't know if you want
Yeah.
to talk about that. I know, I know.
It was so frustrating because we were like so close and all the hard work had kind of been done, and it was just kind of putting the finishing touches, and but the responsible thing, we knew we'd have to just postpone because a lot of us are medical professionals and we're working on the front line. So for people that are tuned in that don't know, Sex Fest essentially was a festival that we were organising for Black and people of colour. It was supposed to happen at the Vagina Museum in April, and then the after party there. It was essentially going to be a series of talks and activities and stalls and stands talking all things sexual reproductive health, from pleasure to gynae conditions to, you know, queer health and all of this kind of stuff that's just so needed outside of kind of just in safe spaces that we need to talk about them. And so it's on hold, it's postponed, because obviously we were expecting kind of, including participants, facilitators, it was going to be like 200 people. So obviously in this current environment can't really do that. But I do think it's such a necessary thing to do, and it's just delayed until a safer time, essentially. And in the meantime, we've got some exciting other projects in the pipeline, which is
excellent. Is there anything that you can share with us, or we got to wait till it's kind of
I think have to wait, because I'm like, oh,
okay.
You know, given Sex Fest, I'm just like, oh, now I'm like, I just want things to like almost happen before now it's just so sad that you have to like postpone or change the plan. But I think it's kind of what people would expect people to be doing in this environment. So I think that like we really want to do a podcast, so hopefully we're going to do that soon. Excellent. And start talking to people, you know, both in and outside the sector, of their experiences. I'm really excited about that. So that's one thing we're kind of working on.
Excellent, sounds brilliant. So I've got a couple of questions, and if there's anything that you want to add or anything you want to ask me, because we kind of want this to be a bit of a dialogue, and we want people to ask questions as well. So we've got a few people kind of tuning into the live. But I guess one of the questions for me, and this is something that I experience as a Black health professional, is how do you find that kind of the challenges as a Black health professional working within sexual reproductive health, and also what kind of are the common things or the common challenges that you see for Black people trying to access care around their reproductive health?
So I think working, first of all, I'll go with the professional and answer the first part of your question. One of the reasons I wanted to, so Decolonizing Contraception is also, it's a collective, it's also a community, and part of that was about finding people with like-minded ideas, and also having like inter-community dialogue amongst Black and people of colour, BIPOC communities, because although we have shared experiences about racism and that kind of thing, we also have really unique and separate experiences. And part of it was that working on these issues as a Black person of African descent, talking about sexual health, I felt quite, you know, isolated. A lot of the, you know, my family is quite religious. I talk about abortion rights quite a lot. It's something I'm quite like passionate about in terms of reproductive justice and choices. And it can be quite an isolating experience sometimes, not having, you know, knowing people that necessarily have shared or that open to speak about these things. And we know they're out there, right? We just know that obviously diaspora population in the UK is small, it's hard to find like-minded people. So one of the things is feeling isolated, feeling that people don't necessarily know your experiences, or people make generalizations or kind of off comments in your presence, how to kind of address those without being seen as kind of angry or irritable or something pompous, people being open to hearing about these things, but then you having to represent like everybody views from like a first generation immigrant from a war-torn country to somebody that is like third generation Caribbean, or because you have the same skin hue, and you being like, I can't possibly give you the experiences of all of these people, you know, I can just give you my view and the view that I think they may want you to know. So I think those are some challenges of just working in healthcare, and, you know, being a minority and having to speak in for all these people. I think in terms of patients and advocacy, I think one of the challenges are, similarly, patients don't see diverse representation. And people can say that, you know, if services are accessible and people are equal and treat people equally, why does that matter? But it does matter, because especially for minoritized groups, because there's such that long history of, you know, sometimes mistrust, or, you know, not the system not really being set up or inclusive for them, that they don't necessarily feel immediately welcomed. And actually having that diverse representation can be like quite an obvious stepping stone to bring people in the immediate way into a service, or make them feel included. Obviously it might not make them stay, because as I said, all skin folk aren't kin folk. So you know, you still have to make that service or that, you know, thing work for people. But diverse representation can be that initial way to show that we are inclusive. We have people that may speak or get your experiences, or were working to do that thing. So I think those are some of the barriers people face, as well as just the more general things, you know, research not really necessarily including the right people. So people don't feel that their experiences are spoken about, or certain medication or things are for them. So those are the common things.
Yeah, it's really interesting that you kind of touch on the idea of like underrepresentation within like research and stuff like that, because I think that's a huge thing. And we kind of come across information. So for example, within, you know, maternity care, that black women, you know, are 5 times more likely to die, you know, in pregnancy and 6, you know, weeks after than their white counterparts. And kind of we've got this information, and then that's kind of it. No one else is sort of, you know, doesn't feel like there's anybody else doing anything. That, you know, research is often motivated by money and outcomes. And so, you know, who is going to benefit by us sort of delving into that, particularly if it sort of brings up maybe a systematic bias, which is much more difficult to correct than putting money into a particular care pathway or something like that. I just wondered if there's a particular, you know, a particular statistic or a particular topic in kind of that sort of reproductive health that you found sort of quite shocking, because when I share that stat with people, like, they often find it really...
So that stat is so shocking, and it's resonated particularly for the last year post the Embrace report, and it's been really important, to be honest, driving conversation and debate and things like that forward. So I'm really, really glad that, like, you know, people are listening because of that statistic. Because, and I think the statistic in maternity services for Black women specifically is so stark, because that's where everyone's vulnerabilities come out. You know, it's harder to advocate for yourself. You kind of just do what someone says because you're worried about, like, your unborn child and things like that. And I think why that statistic is so stark. But I think what I find even kind of sometimes more frustrating is that it took that statistic for people to listen, or it's only taken that statistic for people to have this conversation about healthcare more broadly. And that statistic was bandied about and flying around a year before we saw the COVID inequality statistic, for example. For some of us that work in healthcare and work and talk about healthcare inequality, it was just like these statistics now that we're seeing around COVID were quite unsurprising.
Yeah,
I
absolutely.
just feel like it takes these, like, so COVID, we've seen like Black populations or Black people more time to die or have poor outcomes because of COVID, another like really big statistic. And it's frustrating that it takes like these really obvious health inequality statistics for people to kind of observe what is quite a clear, obvious, profound trend. So what I'd say is that these statistics are helpful in driving your point across, and there are loads. So, you know, Black women are more likely to use repeat contraception. I think it's like 3 times more likely to use emergency contraception. We don't have good statistics on contraception generally, so I don't know what the uptake for long-acting methods are, but I imagine it's low amongst the same demographic. We find that that repeat abortion is higher amongst that same demographic compared to their white counterparts. And a lot of that, the underlying reasons are all going to be the same. Around healthcare access, it's around the fact that people don't want to necessarily take certain contraceptive methods because they have, you know, poor history, or, you know, the counselling hasn't been probably necessarily quite right. But a lot of it drives at the face of like inequality and access, and whether somebody has the time or the ability to go and sit and wait for a particular method of contraception, or those kind of things, or whether they can advocate for themselves, and these things we talked about. And to be honest, it's really similar issues that are translated across the system, and we have to be specific. But when you look at things like, so for anyone that's listening in, I really suggest, if you haven't, even just read the brief of like the Marmot Review, which is a review that was done 10 years ago on health inequality, and they repeated it in 2020 at UCL by Professor Michael Marmot, and it looks at kind of health inequalities across the UK, and it shows quite clearly that disparities are linked to socioeconomic circumstances. Not surprising, we know this, that there's a stalling in life expectancy. It links to things like, you know, if somebody's been incarcerated, people's educational disparities. So, and then obviously those map on quite well to, you know, like how people are racialized, right? So I'm not saying that's the whole story, but essentially I feel that statistics are helpful, but we already kind of know about systemic inequalities, and then people jump on these statistics. And I'm just like, but
there's more.
The media like a headline, right? They love a bite-sized headline.
So I've got a couple of other questions. We had a couple of questions sent in before, but I just want to ask you about sort of, as we kind of talked about underrepresented groups, or in particular sort of like around LGBT and reproductive health in relation to potentially like gender identity and things like that. You know, what do you see happening? What advice do you have for people who are trying to navigate that system and find spaces where they can feel safe?
So it's such a difficult thing, and I have to take my cues from people that are queer and, you know, or non-gender conforming and obviously present that way. You know, I can see how frustrating it is, because similarly I navigate a health system, and, you know, you have to fit into a box, and like often when box, so people ask me a question, I'm like, I wouldn't have phrased it that way. I don't really think that, you know, I relate to these boxes that you're trying to put me in, and it can feel quite alienating. What I'd say is that definitely in medicine we are improving. I'm not saying we're there yet, but I think the healthcare system is improving. Like organisations like the British Association of Sexual Health and HIV produced guidelines for trans and non-binary folk this year. A lot of people are reading it. People that are older are trying to educate themselves. There are people in the system that, you know, around trans health, for example, are trying to educate themselves more. We don't have like necessarily the clear pathways that we require or we'd like to do these things properly, but they are emerging. One thing I would say is that it's really frustrating, but people have to an extent, be their own advocate at the current point. And that's what often I talk about and try to say to people, you need to, you know, not everyone feels this level of confidence, and the onus shouldn't be on you. I completely respect that. I don't think the system should put that on anybody. However, whilst this system is, you know, not built with certain people in mind, and it's not doing what it should do effectively, and we're seeing these health inequalities that we're seeing, you do have to tool up your communities, tool up your friends, and tool up your family. And there are great resources and organisations online, and educating yourself. So I kind of try and tell people how to do that. Often I see people in clinic that are, you know, middle class, often white, more affluent patients that have gone online, done a Google, can come in with a paper that they don't necessarily understand, or even guidelines, or they've asked a friend or something, and they're like, well, I think you should be doing that. And it's not always even done in a aggressive way, or like even a confrontational way. They just know what their agenda is. They've written down a list of questions, and they're just going to hold the doctor to account because they have that level of confidence. And I think we should be doing it more within our communities and not be afraid to say, I've come with this list of questions, or even I want my friend or somebody that is more outspoken or confident to come with me to this appointment because I don't think I can retain that information, or I don't think that I'm going to advocate for myself appropriately. You know, some doctors, some nurses, some other health professionals may feel slightly affronted by it. It's absolutely your right to do so, as long as you're not disrupting your own consultation. And I really strongly believe that is something that people should do and should skill up and can be better advocates for their friends, for their family, for themselves. For example, I go to my hospital appointments with my grandma. You know, she doesn't really understand her medication or her condition particularly well. She doesn't retain the information from her consultations. Often, you know, people are a bit more dismissive, like an older African woman maybe is not as articulate or whatever. I go there, I sit there, I ask the questions, I make the notes, I tell my grandma what she needs to know. Not everyone has that ability or somebody that can do that, but I think that kind of thing helps.
Yeah, that's brilliant. Thank you so much. And I think you've hit on something really interesting there about the kind of power paradigm within healthcare. You know, when you're presenting yourself to someone who you really want to help you, you kind of have a sense of it yourself, but equally you're respecting the fact that they may have trained for a long period of time, and so you almost default and hand over that power. It's something that I talk a lot about when I'm looking after people at the beginning of their maternity journey, and kind of saying, this is yours to own. Like, you know, it doesn't matter what I say, even though you might feel like I'm on your side. Actually, every step of the way, like, take ownership and hold the power, because it is actually yours by default, even if it doesn't really feel that way. So I really appreciate those kind of practical tips that you've given us there. I don't know if maybe off the top of your head, if not, we can kind of add it as a link after, whether there's any sort of organisations apart from sort of Decolonizing Contraception that you've worked alongside or collaborated with, or places you might signpost people to if they are looking to just arm themselves with bits of information.
So generally, I would say that the best things to do is honestly go to the organisations that focus the most on your specific condition. So like reproductive health wise, and these are both run by women of colour. Womb Room is really good, and so Sisters for reproductive conditions, and then like a large organisation like Endometriosis UK, where people have had that condition, they have those experiences, they maybe had surgeries or treatment, and they've navigated those systems, so they know what it's like to have to, you know, access care. We also kind of have done loads of stuff with Prepster, who obviously were built to like advocate for PrEP, and obviously that's been announced as going to be rolled out across the NHS England soon, due to like their brilliant work and other organisations. And again, that organisation is really key in advocating, because it was founded by queer men, also like a queer man of colour, and like he knows what the needs, like a black man, he knows what the needs of, you know, marginalised communities are, and like managed to advocate really, really well. And then there's like more niche other communities that are doing things around just like exploring mental health for queer people of colour, so like Black Fly Zine, and also the Misery Project Club.
Yeah, Misery Club, yeah.
I'm having a bit of a mind. Yeah, people doing really, really great stuff, like trying to bring information in a individual way and create like, you know, sober or like mental health communities for people. So yeah, I think in our guide to sexual health and mental well-being during COVID, we've like written some other organizations down, because I'll miss loads because my mind is fried from work today.
Yeah.
I like that, and partly what DC is really trying to do is try to, you know, we just kind of banded together and was like, yeah, let's go and let's like try doing all this different stuff, and let's have all these conversations, because we're just kind of bored of how people were delivering information, to be honest. And I was like, you know, I see all these awesome communities springing up, that are very like accessing communities through club nights or just community spaces, and they're just ignored by like the mainstream trying to address sexual and reproductive health and even mental health stuff. So I was like, you know, it's time that we just try to band together and try to make more of those spaces and like build our own space.
Yeah, brilliant. That's fantastic. So I guess we can't. Sorry?
Also, on that note, I'd say another reason, because people always get confused about this, and I should have said this at the beginning, like decolonizing contraception talks about all the sexual reproductive health. And the reason we call decolonizing contraception is because that's been such a key area in terms of sexual reproductive health, where both, you know, all communities essentially have faced a lot of stigma around reproduction, and it's been a very forced thing of population control, and it's a key area of sexual reproductive health that is also grossly overlooked. So that's why it's called Decolonizing Contraception. It was born out of that discussion, but we talk about all things, and there aren't very many organizations that advocate for contraception or talk about the barriers to contraception use. So I think that's why it was so important to go that way. And I also thought by talking about decolonizing contraception being inclusive of all gender identities, it highlights that this is not just a conversation to be had for cisgendered women. That is not what the conversation is about.
Yeah, that's fantastic, actually. And I think so I'm quite interested in sort of the terms that we use. So is sexual reproductive health for you, here is your main demographic of people? Does that cover, because I think people instantly think women's health, that's, you know, a term that sort of, they're not interchangeable, but people use them as if they're interchangeable. So when you're talking about, you know, seeing people of all gender identities, the main bulk of your work is around sort of gynae and sexual reproductive health type things.
I come from a community gynae and sexual health background. That's like I'm a doctor in that area. So, but I see people of all gender identities, not just through gynecology, but in a sexual health setting. So I'm passionate about addressing these inequalities across the board. And in terms of decolonizing contraception, it includes people that consider themselves non-binary, like a range of people of gender and gender and sexualities. And, you know, sexual reproductive health is really about all people, because, you know, even if somebody is cisgendered woman, like their partner may not be the same, you know, so regardless, it's relevant. I think because we're called decolonizing contraception, we automatically do attract more cisgendered women, because those are the people that generally use contraception more. But it's about dismantling that conversation. And even in my rhetoric, I often say women. Usually I'll specify, but I also say that a lot because research and data is focused on this demographic, and I usually caveat by saying I'm using this because in the data this is how it's phrased. So I don't know if the people in this data necessarily identified that way. I don't know if there are people outside that demographic that have the same experiences, because research just talks about women, right? And when they collect it as women, that means cisgendered women.
Yeah, brilliant, fabulous. So we're kind of like coming to the end. We kind of wanted to do sort of like 30 minutes or so, but I really wanted to give you an opportunity to talk about like your kind of main passion. Like I've read some of your I've read lots of different articles, and you seem to write about a range of things. I don't know whether that's because you're commissioned to write a particular thing, or, you know, you kind of pitch articles, but what would you say is your main passion, maybe professionally and also for decolonizing contraception, if the two aren't the same?
So I think in terms of my writing, I'm a freelance journalist, and I also have an article which I'm commissioned to write on decolonizing healthcare. Ultimately, I write about what I'm passionate about, and if I'm not passionate about it, I struggle to write. So in terms of having a career as just a freelance writer that can write about all things, I don't think I do particularly well. I stick to medicine, my day job, because if I don't like it, it doesn't interest me. I don't really want to write about it, and I won't really write a very good piece probably. But so
That sounds very familiar to me.
yeah, so what I'm passionate about ultimately is inequality in kind of like all forms. And even myself, I do a lot of self-reflection about, you know, and I'm not here to be on my moralistic high horse, but, you know, I do a lot of self-reflection on my own biases, my own prejudice, questioning those, and trying to make the world a more equal and even place. So that is kind of a common theme within my work. You know, who is not being spoken about, who is not being seen, but also pulling from my own lived experiences and like what I see around me. So I might have anecdotal stories about somebody's experience accessing healthcare, or just somebody's experiencing just navigating the world in general, and be like, oh wow, I didn't even recognize that that was like a problem, whether it's healthcare, whether it's sexual reproductive healthcare, whether it's just life. So that tends to be the common denominator in my work. In terms of decolonizing contraception, really it focuses on, and we're all about sexual reproductive health, because you have to, I think, attack your area of expertise and, you know, try and start off in a manageable area and domain. But like a lot of the issues we talk about in terms of reproductive justice and people having choices, and people being able to, sorry, let's move around, people having choices and people being able to advocate for themselves, ultimately links to wider healthcare issues. So I'm like, if you make space, and I talk about this as well, sexual reproductive health is probably most stigmatized or kind of overlooked or ignored area of healthcare, or one of the most, you know, because of the community it affects, and the stigma around it, and also, you know, people not seeing it as like, you know, hard or necessary medicine or whatever. And so I feel like if you can make changes and highlight the importance of doing this work, then that is something that you can translate onto health inequalities and the rest of medicine, and people can kind of learn from, because we have some of the biggest health disparities like across medicine in terms of the communities we affect, and socioeconomic disparities in who gets diseases and who gets access. So yeah, I think it's ultimately it's inequalities, and it's talking about justice.
Yeah, brilliant. And I think you probably touched on it already, but just for anybody that maybe hasn't heard the term sort of reproductive justice, what do you sort of mean by that term?
So I think the simplicity of it is the simplified way of putting it is giving people, it's not just about choice, but it's also about the ability to have families, raise them well, if that's what you want to do, access care, and have good sexual reproductive health. So I always kind of try to talk about these things through examples. So, you know, it's about understanding the reasons behind why somebody might not be able to access care, for example. So, you know, the fact that somebody's on a 0-hour contract may mean that they can't come in clinic. They might have a STI or a condition that is causing them pelvic pain that could lead to something like pelvic inflammatory disease, which can cause infertility. But because they're on a 0 hours contract and they need to go to work to get paid today to feed their family, all the clinics, they can't travel to clinic because that clinic is halfway across town and they live in, you know, the down and out area. The clinic might be a few bus rides away. They don't have that money. They sit on their condition. They don't get treatment. They get all the complications of that. So it's understanding the lateral policy issues and the lateral life issues that leads to people suffering ill health, and looking at a justice framework around that and saying, how do we correct all the issues around that to improve this inequality and better access?
Amazing. That's so fantastic. I feel really sort of invigorated by your passion. It's really wonderful.
Thank you.
I guess we kind of want to talk a little bit about the current situation that we're in as well with COVID, as we you know, kind of press on. Obviously you're a very busy person, so with the work that you're doing and the kind of with the organisation that you're running, as well as the writing, you know, the freelance kind of work that you're doing as well. So how do you avoid kind of, I guess burnout is the term that people might understand best, but how do you balance everything? How do you switch off from work and then switch on to, you know, other things? Like what's your, if you feel like you've got the balance, maybe, what do you do?
To be honest, a lot of people that know me will say that, like, I'm switched on kind of 24/7, to be honest. I have ideas running through my head and that kind of thing. But I don't think that's sustainable, and I also don't think that it's necessary. And I do think we need to create space and time. And to be honest, sometimes I have a really productive 2 weeks, and then for 1 week I just really can't do any more, and I feel overwhelmed. Yeah. And I think it is really important to draw lines and say, you know, because I work during the day and then I go home and then I have to do DC stuff sometimes, or on the weekends, and maybe having 1 day or 2 days where you just enjoy yourself and you do other things, and recognizing that you are burning out, that the quality of the work isn't good, that you're getting tired. And even this week, you know, I've had to send a few emails where I've just been like, actually, I thought I could do that, or I could meet that deadline, and actually I've got to scale back. I'm getting too tired. Yeah. So, you know, I do have to take time out. I've bought loads of plants during this lockdown. I cycle, I do a lot of exercise, I get that adrenaline rush. But yeah, absolutely recognizing that you don't have time or capacity. I am quite bad at saying no, but I'm getting better at being like, actually, I can't fit that in right now. And you need to be, and you also have to recognize, because DC is a non-profit, for anybody's watching, you can donate through our PayPal and our website, but it's also about saying, you know, like, a lot of the stuff I do for free, and I do because I'm passionate about addressing the issues I mentioned. But sometimes bigger organizations or people come to you for things, and you have to say, well, actually, you either need to pay me or you need to help support the non-profit that I'm trying to do, because we're doing really important work and you want that input. So that's also really important as well.
Yeah, amazing. Thank you so much. As we're kind of talking a little bit about sort of COVID and the restrictions on socialising and stuff, we just had a question from somebody saying, do you think it will be difficult to get people to recognise the importance of smears once the kind of quarantine restrictions have been lifted? Because smears are currently on hold, because I guess considered to be routine care. Is that correct?
Yeah, so a lot of people haven't been having smears because of the routine, and lots of other like little things like that. Even we were supposed to be continuing with vaccinations, but loads of people fallen behind, childhood vaccinations and just other vaccinations like Hep B, HPV, people missed. So I do think that I think that's probably going to be quite a catch-up drive, though, and I've seen people in clinic who are still like, I know when this is over, I need to go and get my smear or whatever. So there will be a backlog, especially for those people that didn't really want to go anyway. They might like now avoid it, right? But I do think that the government and certain organisations are going to try and do a campaign to pick some of that backlog up.
Yeah, brilliant. And we're already kind of seeing, I don't know about in the area that you work in, but where I work, we're already talking about this kind of recovery period, how we try to get back to a new kind of semblance of normal, where we reinstate services. And I don't know whether, I guess your job, as mine, is probably quite difficult to do remotely. But, you know, we've had sort of concerns about people that maybe whose first language isn't English and stuff, and lots of telemedicine that's been happening. You know, what do you kind of see as like the long-reaching effects of not being able to access people? We talked in the last kind of live that I did, I talked a little bit about sort of, well, lots of different things, but accessing abortions, accessing kind of contraception, emergency contraception and things like that. I don't know if you're already seeing some of that kind of come back already.
Unfortunately I am, and I wrote a whole article about this, or I've got an article maybe pending, but I've got a blog that I wrote on the Faculty of Sexual Reproductive Health website on the effects on SRH. So if anybody wants to go read that, that goes into more detail about some of the effects and disparities that we might see. In summary, I think they're going to be vast and potentially long lasting. I do termination clinics, and I've already seen a few patients who were due to have long acting contraception fitted, and are now pregnant because of not getting that long-acting contraception. Even if they were using condoms, we know they're not as effective, and things like that. So and then, as we mentioned, there's going to be backlog of vaccinations, people that are supposed to have Hep B, HPV vaccines. Sometimes communities are difficult to reach already, so we miss opportunistic vaccination there. There are going to be people that are sitting on STI symptoms because they're too scared to access clinical spaces, and they're going to have developed PID. And I've seen a few PIDs, whether it's because they sat on their symptoms because they couldn't have access, I'm not sure, but I definitely think that some of the kind of lockdown was to blame for the delay to the treatment. So yeah, we are going to see some of those we are going to see some complications and a backlog, and it's going to be hard for communities that are already most marginalized. I think people that already struggle to access services at the best of times are going to be even more hard hit. So it will be the same communities, I feel, that end up even worse off.
Yeah. Just when you mentioned PID there, it's pelvic inflammatory disease, just to clarify. Yeah, brilliant. Okay, fab. Just, there's somebody that posted a question about sort of attitudes to cervical screening, but we did touch on it. So I just want to, if you're out there still, can you just let us know if we answered your question? So in kind of, as this is sort of like the final question now, I guess. So what are the things that you want people to take away from today's dialogue? What, you know, if there were sort of maybe 2 or 3 take-home points to just get them thinking, maybe get them acting differently, particularly as a kind of accessing services, but also as a healthcare provider, if they are, what would be the things that you'd want people to take away from this conversation today?
So a quick summary, I'm not really sure if I'll get 3 or loosely 3, but I think advocacy, advocate for yourself, advocate for others, be the change that you want to see. Not everybody can make big steps, but make small steps, and speak to your colleagues, your friends, and you don't need to go off and start something like decolonizing sexual contraception, but you can do small things to change your work environment, make it more friendly for certain people, or do like a small educational teach for your workplace, or even for your friends. You know, like I think that I've done a lot of education within my friendship group to make them more understanding of, you know, the needs of certain populations. And I would hope that they don't work in sexual reproductive health. My friends, some of them are medics, non-medics, you know, but, you know, some of them are anaesthetists, some of them work in general medicine, some of them work in surgery. And I'm like, I hope that when you see a patient that you're not used to seeing, whether that's like a trans patient, a non-binary patient, or whatever, whoever, through the conversations I've had, your interactions with them are better, and you're that less judgmental person in a very judgmental space. So I'm just like, you don't need to do something huge, but you can just be a solid influence in that space.
Brilliant, that's amazing. Thank you so much.
Thanks so much. Just to say, please check out Decolonizing Contraception's work. Check out our website. We're selling murals to raise money for DC in the group on our website that were done by Hazel Mead. And yeah, hopefully we've got some other more interactive things dropping, and we've got some videos from our previous events on our website.
Fantastic, wonderful, brilliant. So everybody, that was Dr Annabel Sowemimo there from Decolonizing Contraception. Thank you very much. Thank you.
Thank you so much for having me. Bye.
Okay, bye.
Bye.
So that's the end of our In Talks With. We've got a link at the bottom there, so please let us know what you thought about today's 21 questions. We'd love to hear from you. There's more coming up later on in the month, so just keep your eyes peeled to the Instagram page. Bye.